Hi, everyone. Thank you for joining us today. I just wanted to give a little introduction before we start. Dr. Koffman, he's a McGill alumni with a degree from the Faculty of Medicine in 1975. He is a doctor, an educator, and a clinical professor turned patient who has dedicated himself to teaching and helping the CLL community since his own CLL diagnosis in 2005. Dr. Koffman believes that his dual status as a retired physician and patient provides a unique experience and understanding, which allows him to provide clear explanations of complex issues and to advocate for his fellow patients. This is especially important in view of the rapidly changing therapeutic landscape. Besides his medical degree, Dr. Koffman has a Master of Science in Medical Education, and he loves to teach. Dr. Koffman is a retired family doctor and clinical professor at the Keck School of Medicine at USC. Dr. Koffman co-founded and serves as the Chief Medical Officer and Executive Vice President of the nonprofit CLL Society, Inc., that is dedicated to the unmet needs of the CLL community in support, education, advocacy, and research. He also has a widely followed blog, and he has shared online and across the world his tough battle with his leukemia, including a failed bone marrow transplant, and his success with 2 phase 1 trials, which he will further elaborate on. So in his presentation today, Dr. Koffman will share his personal journey with cancer and how he beat the odds of a very aggressive prognosis. Dr. Koffman will also share the lessons he learned along his battle, including how to work with experts and how to be strategic in making choices that have a direct impact on your health and well-being. Following his presentation, we will open the Q&A session. So please write your questions in the chat box throughout the session, and they will be submitted privately in the back end, and we'll communicate them to Dr. Koffman for his feedback following his presentation. And then one last note before I turn the virtual mic over to Dr. Koffman. This session is being recorded and will be made available to our alumni community on the alumni website under past events section and on the university's YouTube channel. So Dr. Koffman.
Cynthia, thank you so much for that kind introduction. And I feel very privileged to be here and privileged to be a McGill alumni. Thank you to DOA and the alumni team for setting this up. And please join us if you're in the SoCal area for some of our Los Angeles alumni events and Orange County events that Cynthia helps organize. So we're going to talk about being your own cancer advocate. And you heard the word CLL, that stands for chronic lymphocytic leukemia. It's the most common blood cancer in adults in the Western world. And hopefully I'm going to give you some tools to help you in the fight of your life or that of a loved one when faced with a cancer diagnosis. You've already heard about me, so I'm not going to spend a lot of time on that other than to say I've been a doctor since 1975 and I've been a patient since 2005. So I had 30 years of medical training to train me to become a patient. And I will tell you that the medical training did not prepare me well for being a patient. There was all kinds of other skills that you had to learn. So what we're going to talk about here in terms of our learning objectives is how to increase your odds of staying alive with cancer. And I'm going to try to make this very practical. A little trouble advancing the screen. Let's see, let's try. I want to start by thanking. I always like to not just finish with thanking, but saying thank you and make those of you who aren't in Southern California a little bit jealous of what life can be like here. So the big C, and here the C does not stand for coronavirus, but stands for cancer. And people talk about their life before and after, the new reality. This is a life-changing event when cancer comes to your dinner table. And 2 out of 5 Canadians, that's going to happen for. 1 out of 4 Canadians will die of cancer, slightly more in men than in women. And the numbers are similar in the US. It's the second leading cause of death after heart disease. I'm going to have to disclaim here that this is not intended as medical advice, and all suggestions should be reviewed with your healthcare team. I'm stealing something from my friend Glenn Sabin, who wrote a book called N of One. And for those with a statistical or science background, know that in the N here is standing for the number that were involved in a clinical trial. And this is my N of One, my personal story. And Glenn, in his great book, talks about his N of One. So what did I do? And this is going to be very personal. What did I do to beat the odds? And I'm going to show you the odds in a minute. I'm going to teach you a little bit about how to read some of these charts and stuff. One of the very first things I did was refuse some treatments that were suggested by people that I thought were not up to date on the latest therapies. And it turns out that it was darn good that I did that. And I'll explain how I made those judgments. I ended up hiring and firing a number of healthcare providers. That's all part of building your team. I'm going to talk about that. There's clear evidence that in almost every cancer type, but especially when you get past the big four, lung cancer, breast cancer, prostate cancer, and colon cancer, which are very common. When you get into a cancer that's less common, you really want someone who's familiar with it. You wouldn't want to see a surgeon for your hernia repair who did one hernia a year. You'd want to see someone who did a number every week. And it's the same here. If you have a more of an orphan type cancer, a less common type cancer, that in those cases, you want to make sure that your doctor has an expertise in this, because the therapeutic landscape has advanced so rapidly that getting an expert on your team has been proven over and over again to have a survival advantage. It's also important to become an expert. And if you can't become the expert, maybe you have a family member, maybe you have an adult child, maybe you have a parent, maybe you have a sibling, somebody who can be that expert for you. I'm very big on clinical trials. We're going to spend a lot on that. And especially for those who don't live in countries where there's socialized medicine, and even those who do, how do you get things paid for? How do you get things off formulary? And the importance of talking to other patients belonging to a support group. I can't overemphasize that enough. When you meet a patient who's had the same disease that you've had, and you're like a deer in the headlights with this diagnosis, and you meet someone who's had it for 20 years and survived it, that's the kind of information and experience that no physician, no nurse, no healthcare provider can give you. There are certain things that one patient can give to another that is just so invaluable. What they can't give to another is always credible medical information, but the experience and how to make choices and how to get the support, that is such a critical part of this journey. So I wanted to remind you, remember Doc from Back to the Future, that not all doctors are experts in all things. And this is coming from one doctor talking to you. So become informed, question authority, get a second opinion. People are worried, well, won't I upset my doctor if I get a second opinion? The answer is absolutely not. Doctors are thick-skinned. We don't mind getting a second opinion. If you have a doctor who's worried about you getting a second opinion, consider getting a second doctor, and strongly consider clinical trials. And I just share this as kind of a personal note, and please take a look in the mirror there. And this is kind of my own story. I think you'll find I'm one of the most empathetic doctors around. So my story, I never really wanted to be a self-advocate. That's not what I went about doing. But in order to live as long and as well as possible, I had to become a self-advocate. For those who have a medical or science background, they may have seen something called the Kaplan-Meier curve. And what this is on the horizontal axis, you're seeing years out. And on the vertical axis, you're seeing how many people survive, what's called progression-free survival, who survive without the disease. And if you look at the goal line there, that's the kind of disease I had. And you can see once you get out to about 4 years or less, there's about a 1 in 20 chance of surviving. And as you can do the math here, I'm now 17 years out. So I've definitely beaten those odds by a long shot. But I did it by some of the rules that I'm going to give you. And the first is that you have to make a paradigm shift. You can't drive around in first gear. You have to shift your paradigm. I'm going to talk about the psychological stuff first, and then I'm going to talk about some of the practical issues. So equipoise means balance. You need to be mentally prepared for the battle. And I have a lot of points on this, and you can visit the CLL Society's website for more on that. But the first thing I'm going to talk about is very Zen, and that is controls and illusion. Next, expect the unexpected and underreact. So if you really want control, you have to give up the illusion of control. And you can read the Calvins and Hobbes comic here. So you want some water. Well, I got a big can of it here, and it's up to me to decide if you get water or not. I control your fate. Your very life is in my hands. Without me, you're as good as dead. Without me, you don't. And then it starts to pour rain. So despite making all plans, despite becoming an expert, despite all these things that I'm talking about, sometimes, all the time, these things are beyond our control. So the more you recognize that, the more real control you have. Always expect the unexpected. If you do not expect the unexpected, you will not recognize it when it arrives. And it's very important. Nothing goes as planned is cancer. And underreact. I am going to tell you that for most cancers, you have some time to make some plans. Most cancers are a journey. Most cancers aren't one and done. There's ongoing therapies and follow-ups. So you need to underreact. There's going to be good news. There's going to be bad news. You need to underreact to it all. Again, a very Zen approach to dealing with this. So now let's look at some of the actions and learning points that we've kind of very quickly covered the psychological aspects. And I put this top one in bold because this rings true. This has happened to me several times in my cancer journey, that I've had to make difficult decisions with imperfect knowledge and contradictory advice. When I had one of my major relapses in my cancer, I was seeing two of the top CLL, chronic lymphocytic leukemia experts in the world. And they gave me polar opposite points of view of what my next therapy should be. Completely different. These are guys who published hundreds of papers on CLL, who are really world experts, entirely different. And when I made my decision, which was to go with a brand new experimental therapy called CAR-T, chimeric antigen receptor T-cell therapy, which has been in the news lately. It's a gene therapy, which worked really well for me. The doctor who didn't agree with that, he just hung his head down like this and just said, you know, Brian, if that's what you want to do, okay. But it's just, you have to make if you see a doctor and you have a strep throat, the doctor doesn't have a lot of decisions to make. You know, if you're not allergic to penicillin, you get penicillin. There's no decision points. There's no contradictory advice there. But in cancer, there's often very different paths. Now, some cancers, there's very well-established therapies. If it's this, if it's here, and especially in the big four, there's some really clear answers about what to do. But once you get beyond those four, you're really going to have to understand that you have to make these kind of decisions. Building a team is a critical part of your dealing with cancer long-term. I'm very big on getting expert care, and sometimes that involves two physicians. So maybe you see a world expert. Maybe this is somebody you see once or twice a year. Maybe you have to pay out of pocket to do this, but this is somebody who lives and dies your particular kind of cancer. They research, they publish on this. And this is easy to find out. One of the tricks I do is I use Google Scholar. I put in the name of the kind of cancer that I'm researching, and I look for authors whose names pop up over and over again. And I may not understand what's in there, but I can usually understand the titles of the papers. And you can get a sense of who's an expert, what's a big center, what's going on. Maybe this is somebody you meet through telehealth now. With COVID, that's been much more helpful. But you also need a local expert, and you want these two doctors to play well together in the sandbox. This may come as a big surprise, but some doctors have ego issues. So you want doctors to play well together. And you're also going to need a caregiver, because there's times that you're going to be too tired, too emotionally overwhelmed to make a good decision. We'll talk about that. And I'll talk about our support groups again here, just saying that they can bring an experience. When somebody says, to you. Yeah, I remember the first time I got that infusion and that reaction, and when I broke out in the rash, and look at me now, and I'm doing fine. That's the kind of invaluable advice you can get from a fellow patient. The kind of knowledge you have to develop. The first thing is self-knowledge. And that's what you need to know to demand your own rights. You have to know as much as you can about your cancer, but also your general health. What are your strengths and weaknesses? But you also have to know your own bottom line. What's really important to you? For some people, it's going to be quality of life. For some people, they won't go near your chemotherapy. You've got to let your doctors know about this. For other people, it's quantity of life. They want to live as long as possible. They're willing to fight their way through it. Different people have different approaches. You have to be aware of what your own approaches are going to be. And these can change. And you have to know beyond yourself, what are the options that are available? Are there novel therapies? And I spent a lot of time dealing with personalized or precision medicine, spoken in front of Congress about these things. There are treatments now that are specific, unlike chemo, which sort of kills everything, it grows fast. There are newer novel therapies. Sometimes chemo is still the absolute and best approach for this. What's your healthcare strength, healthcare team strength and weaknesses? This is going to vary from center to center. Some centers specialize in a particular type of cancer, and that's probably where you want to get treated in that type of cancer. But at that center, not everyone is going to be an expert. So you want to find out who that expert is. You want to find out if there's clinical trials available. You want to have that greater support team available. Are there people you can count on to help you, to explain things, to bounce things off? And we'll talk a little bit about more. You want to know what your challenges and opportunities are. So who should do the advocacy? And there's two kinds of approaches, and they're completely compatible and complementary. The first is you do it for yourself. You're your own advocate. It's your life at risk. You've got the skin in the game. You're the ones who have to make the bigs and often the little decisions. The other is that cancer is a team sport, and you're going to need support, and you just can't do this at all. And these both approaches are valid. Is it okay to outsource your own advocacy? And it is, and for reasons that I already mentioned. Sometimes you're just too sick. You're too tired. You're too sick and tired. You're overwhelmed. You're confused. You don't have enough time. Maybe someone on your team is a healthcare professional, can do a better job. As I said at the beginning, being a healthcare professional does not make you a professional patient. You can hand over your advocacy to someone else short term and then take it up later. And you should, if you're thinking about these things, think about who you want to step in on that. Don't try to make that decision when you're going through that rough patch. Make that decision in advance. So I say, being a self-advocate, and I'm coming from both sides of the table because I practiced medicine for a lot of my years as a cancer patient, has to do with being assertive. And there's a difference between being assertive and obnoxious. It's a fine line, but there is a difference. Let me tell you what a doctor really appreciates. The one thing a doctor doesn't have a lot of, and we all wish we do, is more time. So if you feel rushed, believe me, the doctor feels rushed. So we ask you to be direct, state your points clearly, be brief, less is more, provide facts over opinions. If you do this, you're going to leave much happier from the visit. And I'm going to give you one important piece of advice about how to talk to doctors. And that's in the middle of this here, is ask your most important questions first. And ask the most important question first. Because one thing I will tell you as a doctor I hate is when a patient sits there and talks to me about their itchy toenail, and as they're walking out the door, they say, and by the way, that crushing pain I get in the center of my chest when I climb the stairs, that's nothing, is it, doc? This is what they really came in for, but they're bringing it out after we've used up the time for the visit. So always ask your most important questions first. Doctors are thick-skinned. We have to be. A second opinion is always a good idea. Be prepared. There are no dumb questions. So if somebody uses a word that you don't understand, stop in the middle of a sentence and ask. And I will tell you how important it is. Ask the doctor if you can record the sessions. Nowadays, everybody's phones can record sessions. Always a good idea to record, or bring in a partner with you, a scribe or something. My wife and I have left doctor's visits and we've heard entirely different things that the doctor said, and then we listened later. And as usual, my wife was almost always right about what went on during that visit. What we should ask about, does the facility or doctor perform this type of care routinely? Did they have the latest care, targeted or precision personalized medicine? Ask about clinical trials. And clinicaltrials.gov is an international site. It's a US-based site, but it's an international site. How successful has the treatment been in others? What are the side effects, including long-term and late side effects? All drugs are great when they're new because it takes a while to find out what the problems are. You need to know about your other healthcare issues. You have kidney disease, liver disease that can make things worse. Are you going to be able to continue to work? Are there particular hobbies or lifestyle things? Is it really important that you swim every day or do other things that might be affected by this? Going to the gym, playing bridge with friends, or these things that are going to be affected. In the COVID era, what's your immune status going to be? Are you going to be immunocompromised? Is this going to prevent you from traveling? All of these things are things you need to ask about. Also, almost all cancers, that there are cancers where there are therapies that are curative, and those therapies should be tried first. But for a lot of people, you do one therapy and then you do another therapy, and the sequencing of those therapies can be really critical. And you want to say, if I get this therapy now, does that close off the options for me later? What kind of self-care will you need? Every decision should be a shared decision-making between you and your provider. And in the old days, the provider provided all the information, but now the medical information comes from the web, comes from other patients, comes from second opinions. So all that medical information is fed into you as the patient. You bring your needs and values and preferences, and you develop a decision on terms of what to do. Spend a little time on clinical trials. Will you be a guinea pig? What's involved? You won't be a guinea pig because unlike a guinea pig, you have autonomy. What are the pros? You have access to the latest therapies, close supervision, expert care. The trial meds are almost always free. The cons are the unknowns. You could be randomized to the standard of care. It's very rare to be randomized to a placebo unless there's no therapies that work in a cancer trial. And there's possibly more procedures. In dealing with blood cancers, that may mean more imaging like CAT scans and bone marrow biopsies. And there's costs associated with those and with travel. These are the phases of trial. The first is a phase 1, which is a small scale trial, just find out about the dose of the drug and whether it works. The second is usually a single arm trial. There may be different arms at different doses. There's a mixes, a medium-sized trial. And the phase 3 is what's called the registration trial, which compares it to the standard of care to see whether it's safer and works better. And those are the big hundreds of millions of dollar trials that get a drug approved. This is the way it works in the USA, and it's very similar in all other countries. It's not just your doctor looking out for your safety. There's an informed consent. It's voluntary. You can quit the trial at any point. These are the kinds of questions you should be asking when you enter a trial. And I covered a little bit about standard care, randomized. The concept of equipoise means that it's not ethical to do a trial where both options do not offer an advantage to the patient. It would be unethical to set up a straw dog where there's a crappy therapy on one arm and a great therapy on another. And if you feel like you get randomized to an arm that you don't want, you don't have to do the trial. You can drop out at any point. So I think most people know about placebo. Most good randomized trials are double-blinded, which means that the participant and the investigator, the doctor, don't know what's going on. And again, rare in cancer trials for there to be a placebo arm. Who's looking out for you? Again, this is the US data, but there's a ton of people looking under the hood, watching these trials to make sure that they're safe and ethical. This is the kinds of things I ask about. There's inclusion and exclusion criteria. And I think most people will look at these decisions about what's in it for me and am I helping others? And do I feel comfortable with this team? This is a page from clinicaltrials.gov, and it can help you search. And we have, again, stuff on our website in terms of that. So that's my story. How did I beat the odds? Used some treatments. I hired and fired docs. I got docs who were not up to date on how to treat my cancer, who were treating it the way that they learned in medical school or even the way that it was done 5 years ago. But there had been major advances. but because my cancer is quite rare, they don't see a lot of those patients. They didn't know about the new targeted therapies. And if I'd listened to their advice, I wouldn't be here giving this talk today. I built a team. I got an expert. For me, that meant driving in a car for a couple hours to get to an expert, but I did that. And I know that everybody doesn't have that access. Leverage whatever advantages you have. Mine as a physician and educator, I was able to learn and pick up some of this stuff. I'm alive today because of 2 phase 1, those early trials, clinical trials that I jumped in on. And I was excited, and I learned about those trials through other patients who were having good results in those trials. I was able to get insurance to pay for it, and I am still a proud member of a support group. So in the bottom line, there's only 3 things that can be done to promote healing. Learn what it is that you have that needs to be healed. Remove the obstacles that prevent it from being healed, and get the tools that you need. So all of this has to do with knowing what's going on with you, being as healthy as you can for this fight, and then using the tools like medications or other kinds of therapy, surgery, radiation, things like that, to help you with your healing process. So I'm going to end with thank you, and I'm just a couple minutes over time, and I'm looking forward to your questions. Our motto, by the way, at the CLL Society, smart patients get smart care. And you can reach out to me there, and I look forward to your questions. And again, thank you for this opportunity.
Thank you, Dr. Koffman, for sharing your journey and those valuable lessons with us. We're looking forward to hearing more from you in future events. And also thank you to our alumni and guests who attended the session, and for tuning in and sharing your excellent questions. We're going to go through some of the questions to Brian that were in the chat. So one question I have is, what were the telltale signs that you realized that were something wrong and trigger you to seek medical help?
So there's a well-known saying among docs that the doctor who treats himself as a fool for a patient. I was feeling the back of my neck, and I felt some lumps on the back of my neck. And I thought they were like cysts or something, you know, like just a sebaceous cyst, just like a sweat gland that was kind of swollen up. And I completely ignored them for months and months and months because they were painless and they weren't causing me any problems. And I was due for some routine lab work and stuff. So again, the doctor treats himself as a fool for a patient. I ordered some blood work on myself. And I noticed I got these results back. I said, my cholesterol is really good. This is good. I'm vegan, you know, I'm healthy lifestyle. But my white count was really high. And it just hit me like, you know, why is my white count? I'm not sick. I don't have an infection. The white count is a way the body fights off infection. And within a few weeks, I was diagnosed with leukemia. So it wasn't like I had any symptoms like fever or night sweats or weight loss or any of those kinds of things, recurrent infections. It was discovered on a routine lab, just like a lot of, you know, people will find on a mammo, they'll find a little lump in that. But unlike other cancers where when you find it, you want to jump on it, CLL and other cancers that are sometimes like this, or prostate cancer, there's a phase called active observation, because there's no evidence that jumping in early and treating it is helpful. So if you want to talk about cognitive dissonance, the doctor tells you, we have a cancer, it's incurable, we don't have any great therapies, and go away, I'm not going to do anything to help you right now. That, you know, that was the message I got. And it wasn't like that was a bad doctor, that was the reality.
Another question is, what kind of steps do you take during the COVID period when you're around grandchildren, other family members? Do you eat inside? Do you mask all the time if you have young grandchildren who aren't vaccinated?
So let me be clear. Almost all blood cancer patients are immunocompromised. I have a cancer of the immune system. My cancer is something called the B lymphocyte. Lymphocytes are kind of blood cell, and the B lymphocytes are the ones that make antibodies. So I don't make antibodies. You can give me the vaccines. You know, they say if you want to feed someone forever, teach them to fish. I'll never learn how to fish. I don't make antibodies. So the most important thing that I do is wear an N95 mask. And when I have family members over and we're going to eat, then, you know, I live in SoCal, Southern California. So we eat in the backyard, you know, and we sit at separate tables and do that. When we're in the house, we mask. And if we have to eat or something, we try to sit separately at separate tables and be separated as much as we can. I don't eat at restaurants. I don't even eat at outdoor restaurants. I don't go to crowded events. Well, I go to a museum if it's relatively empty and I can be a room and there's hardly any people and I wear a mask. Absolutely, I'll go indoors. Well, I go to a hockey game with, you know, tens of thousands screaming people with no one wearing masks. Absolutely not. I try to stay as healthy as I can in terms of exercise. I think there's some suggestions that being replete, being full of adequate supplies of vitamin D seems to help. I'm less certain of any other kinds of supplements. But the N95 mask is, I think, the most important thing. There are passive immune things that can be done. There's a shot that's available now available in Canada for the last couple of weeks and available in the US since the end of last year, called Evusheld, which is a passive form of immunity, and it provides excellent protection, including against the latest strains of Omicron. So I think that's something, if you're immunocompromised, and anybody who has a blood cancer is immunocompromised, anybody with certain infections, anybody getting chemotherapy or treatment for most cancers, but that's also people on steroids, people who've had kidney transplants, people who have solid organ transplants. A lot of these people are immunosuppressed and would benefit from some of these passive immunity approaches.
Another question I have is, what are some must-have criteria that one should look for in a doctor that one can trust with one's care?
So I think everybody's list is going to be different, and it also depends. I'm going to answer about an oncologist, and you know, doctors have all kinds of jokes about different doctors, but I think what you don't need generally is a great bedside manner from the radiologist who's looking at your chest x-ray, because you're never going to see him or her. And if she does a great job, all you want her to be is excellent at reading your chest x-ray. So her skill level has got to be tops. But what I think in an oncologist, or a hematologist, you want to look for someone who you can communicate with, who listens to you, who hears what your bottom line is. I think that level of communication and trust is going to be critical. I think accessibility is an issue. Does it take you, if you have a question, does it take 5 days to get an answer? In the COVID era, you know, sometimes you got to move really fast. And sometimes you want to go with somebody who knows you and knows your own circumstance, not just with the doctor on call. Is he or she available to you? And are they cutting edge? Is this something that they're interested in? Are they up on the literature? Do they know who the top, if they're not a top researcher, do they at least know who those top researchers are? Do they have clinical trials open to you? Again, you don't always need a clinical trial, but in many cancers, the best treatments are in clinical trials. So these are the kinds of things that I look for in a doctor. And like I say, I've hired and fired many along the way.
Did you change your diet or lifestyle completely?
Another great question. And again, N of one, I'm going to talk about what I do, and this may or may not work for you. So I didn't eat any red meat, though that was pretty hard sometimes, not having Montreal smoked meat, because that was a real weakness. But after I was diagnosed, I became vegan, so no meat, no dairy. I actually lost a fair bit of weight in that, so I added fish in later on. So I eat cold water fish, you know, wild caught cold water fish. We garden, again, we live in Southern California, so we grow a lot of our own plants. I try to eat as much organic as I can. I was never really big on regular exercise. I picked up weight training. There's some clear evidence that high intensity interval training, if your doctor, your buys off on that and says it's safe for you because there's cardiac risks and stuff associated with that, improves your immunity, helps to fight. I think about cancer in terms of seed and soil. So the seed is the cancer, and you've got that seed there, and chemo and other targeted therapies can destroy it, but you want to make the soil as unpleasant. You want to be the nastiest host you can be to that cancer. You want to make it so you want to be as healthy as you can. Your immune surveillance is going to be top notch. You want to be really, really healthy. So I think eating a more of a plant-based diet, regular exercise, regular sunshine, and having a life that's in balance, getting good sleep, having love in your life, all of these things I think really helps.
Is there anything that one can do to be proactive once we find out you're at an early stage of CLL?
So this is a good question. When you're diagnosed with chronic lymphocytic leukemia, is there anything you can do that has been shown to slow the progression of the disease? And that's why I talked at the beginning about control is an illusion. And there's no clear evidence that anything works, but it's very hard. And even though I talk about this control is an illusion, I like to try to do things that make sense, that will be helpful. So that's why I do the exercise and that, in the diet changes and stuff, in the hope that they will help. It gives me a sense that I'm trying to do something rather than just kind of something is being done to me. But the data is pretty thin. That doesn't, lack of evidence doesn't mean evidence of lack. It doesn't mean that it doesn't work. It just means these things haven't been deeply studied. So it just makes sense to me. I already have cancer. I don't want to get heart disease or a stroke or rheumatoid or other things that maybe with lifestyle and other things, diabetes, that I could prevent. So I don't want to get any other comorbidities, other illnesses. So that's how I work on those kinds of things. But actually slowing the cancer, I'd be lying if I said that if you meditate for 4 hours a day and exercise for another 4 hours a day, you're going to slow the cancer down. There's just no evidence. Doesn't mean it doesn't work. There's just no evidence that it does.
According to the CLL Society website, there's no expert CLL physician in Alberta. Do you have any suggestions on how to navigate the Canadian healthcare system to access expert physicians in other provinces?
So this can be a significant issue, especially with the relatively lower population in Canada and the huge geographical challenges. We're really big on telehealth. We're in the process right now of trying to put together we have something called Ask the Expert, which you can send in questions and we'll have an expert respond to those questions for you. And we have an expert access program, which right now is only in the US, but we're hopeful to expand that into Canada soon, where you can actually contact with a Canadian doctor. And we're looking at trying to put together ways where we can have a doctor who's expert from British Columbia or Manitoba consult with a doctor in Alberta or in Northern Ontario where there may not be an expert. We're looking at ways to try to do that. But right now, I'm sorry to say we don't have a great solution for that.
And does gender have an impact on cancer prognosis, healthcare, and recovery odds?
Yes, and it varies, of course, from cancer to cancer. For example, men with breast cancer do much worse than women with breast cancer. There are clearly gender differences in almost all cancers, and there's racial and ethnic differences. African Americans don't do as well with CLL and a lot of other cancers as Caucasians, as whites. And whether that's access problems or hesitancy to enroll in clinical trials based on the history of how they've been mistreated in clinical trials in the past, or whether it's there are genetic factors that are involved. Often we don't have the answers to those questions. So yeah, ethnicity, gender, all important factors in how a cancer progresses. Yeah.
What's the value of seeing a therapist during therapy?
So when you're saying a therapist, I think you're talking about psychological therapy or a social worker or something like that. So this is a rocky journey, and a lot of people with like a diagnosis of CLL or go in for a routine mammo, go in for a routine pap smear, not expecting anything and find out that they have a malignancy, shift from being asymptomatic to suddenly being anxious, depressed, all of these things. And I think if this is something that you're having difficulty moving forward and functioning with, it just really makes sense to get some professional help to guide you through this, because it is almost always going to be a very long journey with bumps and different therapies, starting, stopping. It's not just a decision when to start therapy, sometimes it's a decision when to stop therapy, all of these things. So if you can have that psychological equipoise, that balance, and if you need a professional to do that, by all means do that. I wish I could look you in the eye and say that being a therapist improves your survival. The data just isn't really there to support that. And when I talked about support groups, I'm really big on support groups. There was some early data that suggests, like, especially in breast cancer, which is the best studied, that people in support groups tended to live longer. That data is questioned now, whether that's really statistically significant. But people generally feel better or less happy, or are more happy or less stressed. They have better social life. There's even studies that show they have better sex lives, people who belong to support groups. But whether they live longer, not so sure.
Some doctors don't like an over-informed patient who asks a lot of questions. Is this true? That's what one person has heard.
Of course, I mean, there are good doctors and bad doctors. A doctor who doesn't want an informed patient is a bad doctor. What can I tell you? I crave informed patients, but like I say, I want facts over opinions. I want brief. I don't want people, people will bring in this particular diet, eating this kind of thing, and I get this supplement. I mean, people will bring in, and the doctor doesn't have time to look through 27 supplements in some article that somebody who's selling something, is trying to talk to you about some research in frogs that probably, will never see human light. But generally, if you bring in articles that are published in peer-reviewed journals, that are, high impact journals, the doctors should celebrate that. And I certainly share stuff with my docs all the time. So yes, I do leverage my advantage of being a physician. But I try not to overburden them. I try not to bring things in every meeting. But if there's something critical, I say, hey, I just saw this data and there seems to be this adverse event with this therapy. What do you think? They should be thrilled to see that. So I think you have to hire and fire docs. You have to feel comfortable with your doc.
How long after chemo is one considered immunocompromised? For example, many of us have different types of cancers for which there are no real experts. One person is treated with standard chemo for a similar cancer because there's no good research on it. How do you advocate for ourselves?
So I think there's two different questions there. So let me try to approach them in different ways. It depends on the chemotherapy, but generally, and it's not just chemotherapy, there's therapies called immunotherapies that knock out antibodies. So for example, if people have received a drug called rituximab, which is a very common drug used to treat a lot of blood cancers and lymphomas, you are immunosuppressed for about a year after your last dose. So if you got 6 months of it, then you're immunosuppressed for 18 months and maybe even longer than that. Where other chemos, probably within 60, 90 days, when your blood counts have recovered, you're going to be in better shape. So it's going to vary. There's not a direct answer for that. It depends on the chemo, how much you had. If it's your first round of chemo, if it's your 6th round of chemo, it's going to be different. In terms of cancers where there isn't a clear therapy option, what's happening now in a lot of cancer centers is that people can interrogate the cancer cells and they can look for actionable markers on those cancer cells, actionable pathways that have been corrupted by the cancer, hijacked by the cancer. And there may be a therapy that's normally used to treat lung cancer that's going to work great on your gallbladder cancer because you have the same deficit that's commonly found in lung cancer. So these are called basket trials. You can usually get these drugs off label if there's a good scientific reason for this. It's a little bit of work for your doctors, but this can be done in Canada. This can be done through compassionate use or expanded access programs. So those are the kinds of things that I look for, is to ask, can we do NGS, next generation sequencing? And can we interrogate my cancer cells and see what the genetic markers are? Are there actionable deficits? So this is pretty standard if you go to one of the big cancer centers in the US that they're going to do that. You want to make sure your insurance pays for this, because this is a test that costs thousands of dollars, but it can also be a life-saving test if they find an actionable deficit where there's a therapy that can be helpful.
Dr. Koffman, the prognosis chart you shared was a bit shocking. Is this based on mutations or deletions? Is this prognosis the same for all with CLL?
Super question. I'm so glad you asked that. And you reminded me that there's something I should have said. So all Kaplan-Meier curves, all charts like that are looking backwards. So if you look when this data was published, it was published in 2011. I was diagnosed in 2005, right? It, in order to give 5 years data, had to start that chart in 2006. All the drugs that I've taken have been developed in the last 10 years. So no one on those charts got any of those drugs. And those are really the only drugs that work in those circumstances. So I'm showing you historical data that has no application. Plus, like every cancer, there are baskets, there are buckets of different people. There are some people with CLL, the cancer that I have, that never need treatment. And not just some, 20, 25% of people will have a normal life expectancy and never need treatment. And then there are people that are in a world of pain within 6 months. So there's a broad spectrum. And the other thing to say about statistics is statistics predict for groups. So if you have a group, and I showed a bad prognostic marker called 17p deletion. That's a chromosome that's missing, the short arm of the 17th chromosome, P for petite. And if that's missing, that's where the guardian of the genome, something called P53, that protects against genomic aberrancy and tells the cell, you repair yourself, you're going crazy here, you're not reproducing in a normal way. And if you don't do that, I'm going to kill you. Well, if you're missing that arm, the cancer just gets more and more aberrant and more mutant. And people with deletion of the short arm of the 17th chromosome don't have that guardian of the genome. That protein is missing from them. So they used to have a terrible prognosis because chemo works by damaging the DNA. But if you don't have 17p, you don't care about damaged DNA. You just reproduce the best you can and keep going. But with the new targeted therapies, they work independent of genomic damage, and they're not dependent on that T53 pathway, that 17p pathway. So everything that I showed there is old data and not applicable to the present circumstances in CLL. So I'm sorry if I gave you a scare, and I'm glad you asked me that question.
So we have time for one more question. There are some new therapies that work on change, such as brain spotting and internal family systems. And they say that cancer could be caused by childhood stress. Is there a therapy that can remove the stress from the nervous system?
So I'm not an expert on this, but there's no question that people that are stressed medically, nutritionally, psychologically, environmentally, toxically in childhood often have a much higher incidence of cancer. And we know that when people get one cancer, between that cancer and the treatment for those cancers, which until recently were all quite toxic, patients had a much higher risk of a second cancer. So it's certainly quite possible that psychological damage could lead to similar kinds of circumstances and a higher risk of cancer. And again, like I said, a healthier lifestyle, a way of underreacting to things, a way of self-healing and self-forgiving. I think all of these things can work to diminish your odds. But again, being balanced with the fact that control is an illusion. Like a lot of people, when they're diagnosed with cancer, well, how could this happen to me? I'm like, so I'm a marathon runner. I'm the last person who should get. I'm so healthy. I meditate. I do yoga for 2 hours a day. How can this happen to me? And it's not like you have to. You don't get to choose your parents, right? And we don't get. Often there are some diseases we get to choose to have or not to have. But some cancers we can certainly lower odds, but there's people who never smoke who get lung cancer. Life isn't fair. Don't expect that. You just underreact. Control is an illusion. Expect the unexpected. And just kind of breathe and get your way through it, become an expert, get experts on your team, develop a support network around you. If you don't like the advice you're getting, get some other advice. This is the battle of your life. And it's nobody gets out of here alive, but you want to have as much quality and quantity in your life as you can. And I'm very grateful for this opportunity that McGill has given me and the education that McGill gave me to help me do this stuff. And believe me, a lot of this is timing. If I'd been born 5 years earlier, I wouldn't have had access to these clinical trials. And I got phase 1 of new therapies, genetic therapy, just unheard of. It's like science fiction, and if I'd have born 5 years later, I probably never would have had the bone marrow transplant that I had. But that was the only option I had, and that was a significantly toxic therapy. So a lot of this is about timing, about luck, unfortunately. That's the way it is. So again, thank you for this opportunity, and I look forward to talking again more if it's going to be helpful to people.
Thank you so much, Dr. Koffman, for sharing your journey and these invaluable lessons with us. We're looking forward to future events. And thank you to our alumni and guests who attended this session for tuning in and sharing your excellent questions. For those who were not able to be with us today, keep an eye out for a recording of this webinar that will be made available at McGill's alumni page under past events sometime in June. With that, I wish you all great health and safety, and thank you all, and look forward to seeing you at the next event.